All right, week 10. We literally have this week and 1 week left before you guys are off to module 4, where you start to dive into surgical procedures and you start breaking them down, and then you're in your lab. So we just got this week and a final to get you there and back with Miss Hughes. Now, keep in mind, I do not want you guys to forget the mini session on emergency situations. If you have any questions on anything that was in that mini session, y'all let me know, because it will be on your final, and I want to make sure that you guys are comfortable going into that final exam. With that, I have your final study guides ready. I just want a show of, like, type it in the chat if you want me to wait until Monday, or if you guys are okay with me going ahead and um opening them up tonight or turning the announcement on tonight. I just don't want to overwhelm y'all with so much information, but they are ready. So you guys think about it, and then you guys can kind of type in. I see one person already said open it tonight. So I've got one. I just want to make sure that there is a consensus. Okay, so I got a couple more. So I will have those open up tonight. I just wanted to wait to make sure that it was okay to open it. So it'll have, like, and I haven't done for both of them. So I have 300 and 310 ready, or 310 and 300 both ready. So I'll go ahead and turn those both on tonight. Okay, so just keep in mind, they're going to be in announcements, probably like the bottom one, right? And it'll say study guide for 310 and study guide for 300 in the right courses. Okay. So then that way you guys can have it. Now, with that, for next week, since those are going to be there, I do want you guys, if you have time, to kind of go through them. And if there's anything on those study guides that you're like, I really want to just make sure I'm comfortable with this, send me a message as soon as you can, so that I can kind of go over that for, like, kind of sneak it into, or add it into our week 11's um, live session. Okay. With that, again, I did kind of go through a couple of the finals, trying to capture as much information that I could. And so, just so you guys know, it opens up on Monday at midnight, and it'll close the following Saturday, which is the 20th, at 11:59 p.m. Okay, you guys, 45 minutes to complete 60 questions. Kind of set yourselves up for success, because y'all know technology sometimes does what technology does. So I really want y'all to just be successful. Now, if something does happen, I know I stress it a lot, but if something does happen, reach out to me as soon as possible, because then we have that timestamp, and then I can always kind of present your case, especially if it's like before, and then it just makes it a little bit easier. Okay. Um, um, we're also going to have time this evening to complete your survey for tonight and tomorrow. And don't stress, because we'll still have time next week as well. But y'all know surveys are open, and so we want to get your feedback. With that, we have our quote of the week. Yes, I have it on the right night tonight. Um, Success is no accident. It's hard work, perseverance, learning, studying, sacrifice, and most of all, loving what you're doing, or at least learning to do. Okay. As future techs, this quote just reminds us that success isn't going to happen overnight. It's earned. Okay. You guys are working hard. You have long nights. Life is lifing. You have family, kids, spouses, the whole nine yards. With that, you're mastering a lot of different skills. You're going to be overcoming a lot of challenges, especially when you get into lab and then you actually have those instruments in your hand. And now you have Mr. Avery asking you for knife and hemostat and Army Navy and et cetera, et cetera. You've invested a lot of time in your learning and building that foundation, which is so important in the role that you're about to play, where you're actually playing it now. We're just going through the motions. You see that positive affirmations. Now, again, it takes sacrifice, but you have to love what you're doing. If I didn't love what I'm doing, it would be hard for me to kind of express that. Like, I love being a tech, but I also love teaching. Something that I love. So it makes it easier to kind of express that. And hopefully y'all can feel it. Now, remember that every step that you're taking now is just preparing you for your future. You're going to be the subject matter expert. You're going to be replacing me. And I just want you to know that you are capable of greatness. I know I've said it a lot of times, but your cohort is doing phenomenal. Like, I'm looking back at the last couple courses, not to say they weren't doing phenomenal, but you guys are really like, y'all have stepped it up a notch and we've made it actually harder. So we're sitting back going, okay, yes. I'm so confident as you guys go in, but I also know that sometimes life does happen. So as you're studying, as you're preparing, also, I know I say this often, show yourself some grace, okay? With that, we're getting into chapter 14, general anesthesia. We have some questions from the mini session. Again, if you hadn't seen it, don't stress, okay? Which of the following statements is true regarding the management of mild, hint, hint, mild allergic reaction and the potential escalation of anaphylaxis? Now, this is really big. So we look at A, we look at the H1, H2 receptor antagonists, okay? Benadryl should be used for anaphylaxis as they are effective, but I want you to think about where we are. Okay. Is Benadryl something that we're going to probably give in the operating room? Probably not. So then we look at the other option. If earlier signs of mild allergic reaction, such as skin redness or hives appear, potential triggers should be stopped, meaning like oxygen, propofol, whatever we're actually giving, hint, hint, in the operating room, should be immediately stopped because we don't want it to escalate into anaphylaxis. Okay, so we look at those two and we start to exactly. We look at what we can eliminate. Okay. Benadryl is not necessarily something we're given in the operating room. Granted, we know as a civilian, as an OTC, over the counter medication, we can grab that for any type of allergic reaction. So that's why B is the correct answer. Now, this chapter has a lot of terminology. Okay, you guys, a lot. So just have a good way to differentiate it. You will get a Quizlet that has a lot of the terms for this entire course. So that will help. But get some flashcards and just kind of work them through. Okay. Again, you will get that Quizlet that has, I think, all of these terms on it, but sometimes it's good to kind of rewrite them. For me, rewriting it on my own and kind of like having an additional resource, computer and written, does help. I'm kind of old school that way. But lots and lots of terms. Okay. So again, you may see a lot of them on the final exam. Real quick, I know this is off topic, but I just wanted to mention for ST300, the video was no sound. Okay, thank you for letting me know. I will kind of look at that before anyone else runs into the problem. So keep in mind the video doesn't have sound. I'm going to check that out and see. I may have to kind of figure it out or change it. But thank you, Miss Rebecca, for letting me know. All right. Now, tonight, we look at just the basics of anesthesia, right? We're looking at the nerve ending. This is where that pain is detected, and then it sends signals through the nerve. Our nerves are the pathways. So they're the ones that are going to carry that signal through our spinal cord. The chapter talks about your sensory and motor nerves. These are going to be um, the motor nerves, how they're controlling our movement. All right. Now, our spinal cord acts as like your relay station. It's passing the pain signals from the nerves to our brain. And then the brain determines, like, oh, that's pain. I should probably move my hand, move my foot, or whatever it is that's causing it. So it's interpreting the pain signals and creates the sensation of what we feel is actual pain. In one of my other classes, I talk about a disease where there are individuals that just don't feel pain. And I always pose this question, so I pose it to you guys today. What would be a con of not feeling pain? And I want you to think about that as we continue to go through tonight's live session. So, how does pain actually travel? Now, your nerve endings are stimulated. So, the pain begins with that nerve ending. It detects that there's some type of harmful stimulus. Signals are sent through the nerves, right? Again, to the spinal cord. And then the spinal cord processes that signal, potentially triggering that reflex. Like you're touching something hot and your hand comes back. Again, the brain is the one that's like, hey, you shouldn't be having your hand on that hot fire because, it's not really that good. And so when, say, Miss Desiree got it, not knowing when tissue damage is occurring. So a lot of those individuals that do not have pain sensation, they go through a lot of injuries and not knowing it, which can actually be problematic, especially on little babies and toddlers, where that's where they're learning to stop touching hot stuff. So if you have a little one, 2, 3, and they're not complaining of pain, and that could potentially cause a lot of issues later. Okay. Now, we have systemic anesthesia that we have to look at, okay, where we're talking about affecting the entire body rather than just regional or local, meaning site. Now, with systemic anesthesia, we're trying to prevent the brain from interpreting pain signals from anywhere in the body. It's ideal for the surgeries with multiple sites or areas that are hard to block regionally, usually in the belly. Like if a patient has a big belly case, we're not sticking a bunch of needles trying to numb the internal organs. It's just not going to be plausible. So they're most definitely going under general anesthesia. Now, we have examples like skin grafts, breast reconstructions, autologous bone grafts as well, where we're taking a graft from the patient's own body and reusing it in another part. We do that a lot of times with our ACLs. Now, systemic anesthesia makes sure that there's complete pain control. It is very complex and not just for those 4 cases that I mentioned. Okay. There are 2 main factors if general anesthesia is appropriate. You may see this again. We look at surgical procedures, for example. It's going to be needed for surgeries involving multiple areas. Skin grafts, for example, you may have multiple sites. We also are going to use it for long surgeries. We're not going to try to keep numbing our patient if we know we're going to be in a case for like 6 to 12 hours, right? That's going to be kind of torturous. But there's also patient factors. So surgical procedure and patient factors. We look at their age. We look at their cognitive ability. We look at their mental state and their emotional readiness. It's also patient preference. It does matter, especially if they fear needles or they are anxious. Now, depending on your facility, a lot of times at the surgery site, I don't know if I've mentioned, I think, yeah, I've mentioned in this class that a lot of times we're going to be helping prepare the anesthesia cart for our anesthesia provider. At a bigger facility, we have anesthesia techs that come in and kind of do that whole thing. Okay. But it's still good to kind of know where the things are in case an emergency comes. You're a runner and anesthesia tech is busy and they ask, hey, can you run to the anesthesia room and grab something really quick? Okay. Now, we look at the anesthesia workstation components itself. You have manual automatic ventilation systems, you have breathing circuits, you have oxygen nitrous oxide supply, vaporizers, pressure regulators, gas mixing signals, and a gas scavenging system. Now, most likely, what you'll be changing, if you have to, would probably just be the hoses and everything that is connected to the patient, because a lot of this, the anesthesia provider will check before the day even starts. Okay. Now, alarms will go off when readiness or let's say something is out of limits. Just like with anything else, you're going to get that alarm to let you know, hey, something's not going on. Now, the goal of general anesthesia is to prevent awareness during surgery. We don't want a patient to sit up if we have a drill going into their bone or if we are um, running the bowel, for example. Like say we think that there's something obstructed in their intestines and we're running it to make sure there's nothing there. We don't want a patient to sit up. That would, one, scare us, and two, that's not really good for the patient. Now, when we talk about analgesia, that's just blocking the pain. Amnesia prevents memory of the procedure, like giving the patient first aid or something like that. We look at them being immobile. Again, we're not wanting them to sit up during the case, so we want to make sure that they remain still. The goals of having the patient unconscious. Again, the patient is unaware. We don't want them to respond to any type of stimuli. With these goals, we're trying to make sure we keep that patient comfortable, and safe during the entire procedure. So, how do we give them this said general anesthesia? Well, there's a couple ways, and the chapter talks about intravenous or IV, where the anesthetic drug is directed directly into the bloodstream. For our little ones, a lot of times we'll have like the little gas. So gases or vapors are inhaled through a mask or a tube, and then we put them kind of like put them to sleep. It can be a balance of IV and inhalation methods, which is the optimal effect. Now, what's less common is that a regional block may be used with just a light or general anesthetic, typically for our more high risk patients. Again, hint, hint, this approach is rare, but can provide additional safety in some different cases. Now, again, these methods are going to be tailored to the patient's needs and the surgical procedure. I have seen many questions on CST exams, of course, different concepts on your final on the phases of general anesthetics or anesthesia. So we look at pre-induction. This is preoperative, the assessment, and the patient is being prepared. Okay, so we're bringing them in, whether they're walking, they're on the gurney, they're on a wheelchair, they're coming into the operating room, and we're just getting them set up. We're telling them to relax. We're hooking them up to everything. I say we, use our circulator, but if you have scrubbed in and you've broken, sometimes you're free. Okay, now induction is when the administration of the anesthetic agent is helping the patient become unconscious. Once they're unconscious, we go into the maintenance stage where we're keeping the patient stable and unconscious during the surgical procedure. Now, once anesthesia hears that closing stitch, they start to gradually awaken the patient, or the anesthesia starts to wear off. And then when we look at recovery, this is going to be the post-operative phase where the patient recovers in the PACU. Now, each phase makes sure that that patient is safe and comfortable throughout the entire surgical procedure. And again, you can kind of see the anesthesia workstation and everything that is entailed with it from this kind of like bird's eye view. So let's break it down a little bit more. Now, pre-induction stage begins when the patient is admitted into the preoperative holding area. I will repeat this because I have seen this concept missed a couple times. Pre-induction phase itself begins when the patient is admitted into the preoperative holding area. So assessment is being done. They're looking at the patient's health. They're looking at the readiness. Patient is looked at for their physical and psychological readiness. And then they come to us. They're going to be given oxygen, just extra oxygen in the operating room. This is done before anesthesia. Okay. Then our anesthesia provider is going to administer the anesthetic. Okay. Induction starts when the anesthetic medications are administered to initiate general anesthesia. It ends when the patient reaches an adequate depth of anesthesia and their airway is secured, so that they've been intubated, tubes are usually taped into place. They may put some ointment in the eyes, tape over them. Okay, now the induction phase is the first step in the interoperative period following pre-induction and is so important for ensuring that the patient is safe and is deeply anesthetized. Are you guys still with me so far? Okay. Now, we look at our airway management. Now, I mentioned the patient being intubated, but there are other ways where we can, where the anesthesia provider will do airways as well. We have our mask where it's just placed over the nose. It's going to be suitable for, like, let's say a short procedure like an ear tube or myringotomy. It supports respiration during surgery without complete muscle relaxation, because really those cases are literally 15-30 minutes tops usually. We have what's called a laryngeal mask airway, or an LMA. It sits on the top of the larynx, and it delivers oxygen and anesthetic gases, again for short procedures, particularly in more of the ambulatory surgery center realm. But there are contraindications. It's not recommended for oral surgeries for obvious reasons, right? Um, Obesity patients, hiatal hernias, GERD, or low pulmonary compliance. We have our endotracheal airway, or ETA, with intubation. This provides the maximum airway control. It's going to be used for our longer surgeries, deep muscle relaxation, or when the patient is going to be in prone on their stomach, or even lateral position. So let's say we're doing a spinal case or a kidney case. So spinal, let's say we're doing lumbar case, patient's prone, they're on their stomach, or again, like I said, a kidney case, they'll be on their side. Now, there are some variations. You can do a nasal intubation or even a awake intubation. These are going to provide precise control for airway management, especially in surgeries that are longer, or in, let's say the patient's in like a complex position. Now, when we talk about the ET tube insertion, granted, it's not something that you're going to be doing, but you may be assisting with cricoid pressure. Okay, again, we're with so many things going on simultaneously, you may have set up your back table, your Mayo stand, and have broken scrub. Okay. But again, that's going to be facilities policy, and you're going to be following what your preceptor does. Okay. And says, remember, you're a sponge. Now, with muscle relaxants, we're talking about short acting muscle relaxant is going to be administered because we want to ease the intubation. Where you don't see this, the anesthesia provider just count to 10 and then sticking the tube down their throat, right? That would cause really a laryngospasm, and we don't want the patient to have any type of issues. The ET tube is inserted through the patient's mouth into the trachea. So they're going to check, okay? They're not going to be like, oh, we're in there, we're good. They're going to auscultate, meaning they're going to take their stethoscope and they're going to listen to the lung sounds to make sure they are indeed in the right spot. They're measuring CO2 levels as well to confirm that, yes, we are indeed in the right position. Now, the use of laryngoscopes does help with visualization and placing the ET tube correctly. Figure 15.6 in your chapter really kind of shows you as well, okay? So that's the first half. Now, in 14.2, now we're looking at phases of surgical procedures, including just awareness under anesthesia and muscle relaxation. We've got to talk about that emergent phase of the surgical procedure, especially when it comes to extubation, because that's big. We have to identify the categories of anesthesia medications. We have to look at IV induction agents, including why we're using them. But we're not done. There's a lot. We're going to look at analgesics compared to opioids. We're also going to look at inhalation agents, blocking agents, comparing depolarizing and non-polarizing muscle relaxants, and reversal agents, because once you put something in, you still have to be able to reverse if the patient has an allergic reaction. And that's with everything. So, the induction phase. Patients are highly reactive to noise, to stimulus. They may experience agitation or even excitement. So it's important for us and our entire surgical team to kind of minimize noise and sudden movements during this time. You may have an anesthesiologist that says quiet on deck, okay, and they're getting ready, and you'll turn around, you're like, okay, they're getting ready to intubate. You may have some anesthesiologists or CRNAs that have their own way of kind of like letting you know, like, it's getting ready to happen. Now, reducing distractions will help the patient's stress or any type of discomfort that they're feeling as they transition to the different types of anesthesia. So we're just trying to be mindful that we're not picking up big instruments and slamming them down, okay, which you're not going to be doing. Now, Again, with that maintenance phase, the patient's getting stable. We're golden. Again, it continues throughout our entire procedure. Our CRNA or our anesthesia provider is going to give medications as needed. Let's say the case goes a lot longer. So the amount that they had for the patient based on their weight, the age, now they need to add a little bit more, or the reverse happens. We'll talk about that. Now, this phase makes sure that the patient remains adequately anesthetized and stable during the entire surgery. Now, awareness during surgery is rare, but some patients may recall or have explicit memories of events that occurred during their actual surgery, which is known as intraoperative awareness. You may see that somewhere. Now, this occurs in about 20,000 to 40,000 cases annually in the United States. Patients with a history of, let's say, substance abuse, or maybe they have a lot of chronic pain, are more likely to experience this because their tolerance for the medication or any medication is a little bit higher. So we just have to be aware that patients may hear and remember conversations during surgery. We can no longer assume that the patient is completely unaware. So, of course, we're going to maintain professionalism and avoid casual or inappropriate comments because you just never know if the patient is one that, may have had chronic pain. So their tolerance may be a little bit higher. Now, with long-acting muscle relaxants, these are commonly given under the maintenance phase because we're trying to keep the patient relaxed. Proper timing of muscle relaxants is going to be really important because we're trying to ensure that the patient remains relaxed only as needed. So the question is, do those fall under near misses or medical negligence? No, um, because, and I say no because of the fact that with near misses, this is something that could have prevented harm to the patient, right? Medical negligence, you're doing something again that's going to cause harm. This doesn't necessarily fall under medical negligence because every patient reacts to medications differently. So you're not doing anything to harm them. You're going to give them the adequate amount of dosage and then you will adjust as you go. Does that make sense? Okay. A great question, by the way. Um, so we get into proper timing. Got to make sure that, again, based on the patient's age, weight, and all the other items, that we've got the timing right. We look at the depth. How deep are we getting this patient? So it's checked with peripheral nerve stimulus to just make sure that, okay, we're at the correct level. So that means that timing is important. They should last through the closure. And if you notice when I said, usually when the anesthesia provider sees that closing stitch, they're already trying to make sure that they have enough to start waking it up. Also, if they know that a resident or a fellow is going to close, and if that person's a little bit slower, I have seen anesthesia providers go ahead and start waking them up. Even though that fellow or intern or resident may be a little bit slower, they're still going to be waking them up to kind of help. Okay. Now, this approach helps make sure that the patient is going to be relaxed again. So we're going to continue to keep that patient relaxed during surgery. Now, most of you, I don't know if you've seen the movie Awake. That really kind of like, for me, was like, whoa, because not only was this patient aware, granted, it was Hollywood, but he could feel everything, which completely took me to another level. The rest of the movie was Hollywood, but that particular portion really stood out to me. When we talk about the emergent phase, it begins at the end of a surgical procedure. Anesthetics are discontinued or in some cases just allowed to wear off. The patient starts to wake up. The airway is removed, PRN, and the phase ends when the patient is transported to the PACU. So it's really important to know that during the emergent stage, patients again are highly reactive to noise and movements, like startling. Have you ever woken up suddenly from a noise, that feeling you get like you're, oh my goodness, what just happened, right? Think about that. That's where the patients are kind of feeling at that stage. So again, just like we were kind of quiet on set in the beginning, we kind of let that patient wake up in that same manner so they don't get that startled, like, oh my goodness, what happened effect. Now, extubation. So at the children's hospital, we tend to extubate our kids um, in the OR, okay? But it's based on facilities. Some facilities, it just depends. But extubation is where the endotracheal tube is removed once the patient is sufficiently awake and stable. Now, oxygen may be given if needed. And the anesthesia care provider gives that full report of what happened on their side to the nursing staff in PACU. But there are some things to consider with the airway. The patient has to be breathing on their own and able to kind of maintain their airway independently before the ET tube is removed. So that's one thing that our CRNAs or our anesthesia providers are taking care of. And then again, we come back to that recovery phase. This is when the patient is in PACU. The patient is fully awake and the vital signs are stable, and the patient is ready to be discharged from the PACU. The recovery phase is the final postoperative phase of general anesthesia. I will repeat that. The recovery phase is the final postoperative phase of general anesthesia, and it focuses on just really monitoring and making sure that the patient is safe as they regain full consciousness and their stability. Now, we get into categories of anesthetics. We're trying to, again, induce that unconsciousness at the start of anesthesia. We're trying to prevent the sensation of pain during surgery because we don't want anyone to be like the movie Awake. That was crazy because he could feel them cracking his ribs. He was having a heart transplant, just so you guys know. Imagine being awake for that, but not being awake, if that makes sense. Now, with analgesics, we're trying to prevent the sensation of pain during the procedure. We are inducing unconsciousness. We're trying to prevent that motor response to painful stimuli. We look at neuromuscular blockers, okay, where you have induction of unconsciousness and now you're not feeling anything. And this is really good during a surgical procedure. So this little video that you're going to see, it'll be in the archive. It's just a 3-minute video on just that, on blocking agents, okay? Again, not something that you're required, but it is there if you're curious. So I kind of wanted you to see what you will see in the archive section, okay? Now, reversal agents are important because they're going to counteract effects of other anesthetic agents to assist in recovery. Each medication type contributes to really achieving the desired components of general anesthesia. And it makes sure that the patient remains unconscious, pain-free, and relaxed during surgery. So, have a chart for you guys. This is in the book. Okay, it's 15-1. Opioids are key categories of analgesics that are used to manage pain. They can be either natural or created in a lab. So you have natural opioids. Morphine and codeine, believe it or not, are natural. Your synthetic ones are going to be your fentanyl, your aflatina, sulfentanyl, and rimifentanil. Now, the role in anesthesia is that opioids are administered during that maintenance phase. Remember what the maintenance phase is. And it's going to help to really prevent and make sure the patient remains comfortable throughout the procedure. These drugs are commonly used because of their morphine-like effects, which help really manage pain effectively. We get into inhalation agents, types of inhalation agents like nitrous oxide. Most widely used inhalation anesthetic. You have some more volatile liquid anesthetics, isoflurane, you have desiflurane and sevoflurane. These are, again, volatile agents, and they're stored in their liquid form, and they are poured into the vaporizer. So this is where you see anesthesia, they're over, or your anesthesia provider over there, and they're mixing their different things, and they're converted to gas, and this is what the patient is inhaling when they have that mask on their face. So we measure the potency. We have the minimum alveolar concentration. This is going to kind of let us know the concentration needed to stop motor response to a surgical incision in 50% of patients. But there are disadvantages of having those inhalation agents versus going straight in with everything. They can cause a decrease in heart function. There is a lack of post-operative analgesics, so they do not provide pain relief after surgery, and that's where the patient may require additional analgesics or pain meds. And there's factors influencing selection. The choice of inhalation agent depends on the factors like solubility of the gas and the patient's cardiac output. Now, inhalation agents are extremely important because they're helping maintain anesthesia, but they have to be carefully chosen to minimize side effects and ensure effective pain management. We talk about reversal agents, okay? Narcan is one you guys probably have heard a lot of, okay? Narcan. You have nalmefene, you have naltrexone. Now, these agents reverse the effects of opioids. Benzodiazepams. These reverse the sedative effects, or you have flumazenil. I love the terms that reverse the effects of benzodiazepines. Now, for your non-polarizing muscle relaxants, you have progesterone and tinsolin. And these agents reverse the muscle relaxants caused by non-polarizing muscle relaxants. And they allow for recovery of muscle function. Now, reversal agents are going to be just as important because we're trying to help the patients recover from anesthetics, especially when the procedures are unexpectedly shortened or when faster recovery is desired. So let's say you have a gallbladder case, cholecystectomy, with a cholangiogram, and they decide not to do the cholangiogram, and then you go from, let's say, a 2-hour case to now a 45-minute case, right? Well, the patient was placed under anesthetics for that 2 hours, so now they have to do a reversal agent to kind of bring them awake around the same time closing happens. And yes, that does happen. But the reverse happens as well, where the patient may be scheduled for, let's say, a regular hour-and-a-half case, and something happens where it goes longer. So then the opposite would have to happen. So they would give them more anesthetics to keep them comfortable for the longer period or the unexpected period of being under anesthetics. Now, that was all. Before that, I do want to go over a couple more questions from the mini session. Again, if you haven't watched it, y'all know it's okay. But here's some things. Which of the following is the first and most reliable sign of malignant hypothermia that healthcare providers should monitor for during anesthesia? Is it tachypnea, which is rapid breathing, or increase in end-tidal CO2? It is option B. And it's because of the increase in tidal CO2 is the first and most reliable sign of malignant hypothermia. It indicates that there's a lot of CO2 being built up, and that is caused by it's the hypermetabolic muscle activity, which is a key feature of malignant hypothermia. So that's why you'll see that the anesthesia provider is monitoring that end-tidal CO2. And when they detect early signs, that's going to be the most consistent indicator. And remember that malignant hypothermia is a life-threatening condition. Okay. Here is another question before we get into our survey. Which of the following is a key role of the ST during malignant management of malignant hyperthermia? Is it the administration of dantrolene to reverse the effects of MH, or assisting with oxygen administration cooling that patient down, and preparing medications for the team. Yes, it is B. We are not giving the dantrolene. It's going to be usually your circulator, anesthesia provider, but we could be assisting with oxygen, helping trying to get that patient cooled down, and we could be kind of grabbing medications for them to prepare to give, to our team. Good job. All right. So here it is. We want to hear from you. Okay. Your voice matters. I always feel like I am on a commercial during this time, but go with it. The survey is about 5 to 10 minutes, as you guys know, and it's just a small investment of your time to let us know, what we can fix. We can't fix it if we do not know there is a problem. Okay. And we really want your feedback because your opinion matters. We want to make sure that this is an amazing program for you and for those coming up after you. So, 5 minutes, take your time, and then we will be back. If I can get it. Okay, there we go. All right. With that, what questions do you have for me on this week 10 of Theory 2? So if something does come up, y'all, go ahead and let me know. Again, I'm going to go ahead and put the study guides up tonight. Actually, as soon as we're done here, I'm going to go ahead and open up those announcements for you guys so you can kind of see them. If there's a concept on there that you're like, I feel comfortable, but I want another breakdown, y'all let me know. The more information y'all send me, we can kind of like break it down next week so that you are going into that final exam confident. Okay. You guys know the information. It's just making sure you're confident going in there and not second guessing. Because that's one of the things that I do a lot on exams is I second guess. And I want y'all going in there knowing that you know that you know. Okay. With that, I want you guys to have a wonderful rest of your evening. Hold on. For those of you watching the archive, I almost forgot. How do the properties of inhalation versus intravenous anesthetics affect anesthesia management? What steps can the surgical team take to prevent awareness under anesthesia, if there are? And how could improvements in neuromuscular blockers benefit high risk patients? Quote of the week: success is no accident. It's hard work, perseverance, learning, studying, sacrifice, and most of all, loving what you are doing or learning to do. Now, with that, you guys have a wonderful rest of your evening, and I look forward to everyone who can attend tomorrow's live session. Good night, everybody.